The special 2-hour edition this week of the Dr. Payne Show. Dr. Lou is here. 416-870-6400, star 640 on cell. Talking your pain concerns, health concerns. Bring them on. Love your phone calls. Just bring it out there. We will, or at least he will, answer as much as he can through the course of the next couple hours. Week that was a look back at things been happening with the clinic. What's going on, pal?
Yeah, I had an interesting case this week where I was talking to a patient that had a low back issue. The case itself, what was wrong with him, doesn't really matter as much as the point that I wanted to highlight. So I saw this individual, very, very acute, couldn't almost move. He was almost hobbled in. And as soon as I saw him, I said, you need medication. You need hard meds right now. I gotta send you to one of my colleagues. They'll get you hooked up very nicely, and you'll get doped up a little bit, and you'll start to feel. And you got to get it. And he turned to me, said, "No, absolutely not. I don't believe in medication." Right. And it just brought to my attention what I often hear. You meet some people who say, I don't believe in medication. Then you meet other people who say, I don't believe in alternative healthcare. Right. And you start talking about these beliefs like healthcare has become a religion or something. Right. And it's just really funny because I try to educate everyone. And what I do on this show, and people have heard me say it a million times, is everything in healthcare has its place. Yes. Medications, alternative medicine, surgery, et cetera, et cetera. My job is to make the recommendation that I believe is going to be best for you. Now, having said that, part of the informed consent of being a patient is also what you want. So if medication is not something that you want, it can't be forced down your throat.
For
and
sure.
But it just highlighted the fact of how many people out there, and when you start talking to these people, there's no good, belief system to why they believe that. It's just they've read some type of a book, or they've talked to one of their friends or whatever, and it's like, no, there's...
I've heard, I've done.
They say, exactly, yeah. They say, and it's like, well, is they a publication, a research publication? Because if it's not, I don't know how accurate it is. But I do think that what's important to understand moving forward in healthcare is I do think we have to start eliminating this notion of I believe in this one way and I believe in this other way, right. and really start looking at healthcare as a spectrum of everything needs to play a role. And the best examples of great clinics around the world that have some of the very best care all work in that model where they have a full integrative approach to healthcare, where they're using every single thing that's available, whether it's medication, surgery, alternative medicines, other different types of therapies, et cetera, because that's what works, is using that all-inclusive, multidisciplinary, multimodal approach to healthcare is absolutely the key. And, it's something that I really wanted to highlight today is how important that is, to have an open mind towards everything and understand that everything has its place. Now, obviously, if you've been given narcotics and they're not stopping on it, then that's bad. But it's the same thing as, it's funny because you meet a lot of people who don't believe in the alternative, I'll call it healthcare side of things, and others who don't believe the other side of things. And it is frustrating because I do believe these people are actually hindering their care by not being open to the other options that are available. And sometimes you have to understand where you're going, right? If you're going to a clinic that's only going to push meds down you, then maybe that's not the best idea. And if you're going somewhere where they're only going to push that, but that's what I've tried to do different, is build an all-inclusive team where we're including every single type of therapy in the management plan. And again, whatever is set to work best. And a lot of times it's trial and error with certain things. But what I always say is that the things that are least invasive are going to be very safe to try. There's very little risk, very little side effect, versus once you start moving to the more serious things, they have higher risks associated, and the potential benefit may also be better. But you have to be able to weigh that as a consumer of healthcare. Right. We have to also start thinking of ourselves as being consumers of healthcare. And you have to realize that, in my opinion, it is always most worthwhile to try least invasive things before moving to the more invasive things. And, sometimes I meet people who it's like, I just want to do surgery for this. It's like, yeah, but no surgeon's going to operate on you for this particular problem because you're not a surgical candidate. You also have to qualify for certain types of therapies, especially when you start to get into things like surgery where now you're playing with life and death, right? A surgeon wants to understand that if he or she is going to put you on the table, that there's going to be potentially a good outcome to that surgery. And
benefit.
Yeah, cost benefit, exactly. And so this is a very, very important thing for people that are listening to share with them, for them to understand, to share with their loved ones, because it just seems to be the way. And it's funny because when I I don't have any good research, but clinically what I see, when you meet the older generation of patients, those are the ones that seem to be more about, I only believe in medicine and the alternative stuff, no way. And now as we start to get into the new generation, it's kind of switching where it's like, no, only alternative stuff. I don't believe in medicine. And, again, there's a happy medium of everything. I do really think the key is moderation. And when you're working with someone whose goal is just simply to get you better, they're going to make the recommendations that you need. And sometimes those things are very, very important. But I think that any decision that someone makes should be based in good research, good evidence, good suggestions by a good professional, and not just because they say or my uncle or my aunt or whatever said this. No, let's base it on good, hard facts because that's going to be your best chance for outcome. Because when you minimize yourself that way, when you have that preconceived belief, you also minimize your chances of getting better.
We'll take a short break on that one and your phone calls. You have an opinion, have questions, you have pain, give us a call. Give Dr. Lou a call. He's here, 416-870-6400, star 640 on cell. Just getting rolling, the 2-hour edition of the Dr. Payne Show, Talk Radio, AM 640. It is 11:14. We'll get to your phone calls momentarily. By the way, we got lots of open lines you'd like to call in this morning with your concerns. Would love to hear from you. But first,
I see the calls. Hang on, because I gotta get this off my system.
Uh-oh.
So we just first talked about the patients and their preconceived beliefs about one way or the other. Now, what's also just as bad is when you meet healthcare professionals that are set in one way, right? So I've heard a lot of horror stories about the alternative side of things, and even on the more traditional Western approach. But I think you should always be careful when you're dealing with a healthcare professional who's telling you, no, don't go that other route because that's bad, that's evil, right? And it's funny because I've talked to a lot of these people that have these views about, no, I only believe in the alternative, or I only believe in the traditional Western approach. And when I talk to these people, their argument is often, well, I say, why do you believe in that approach? Why is it that? And they say, because the other one just treats a symptom. It doesn't treat the cause, and it makes it reductionistic. And I sit there and I say, well, isn't your outlook on believing that your therapy is the only thing that helps just as reductionistic as the other person who believes that their therapy is the only thing that can work? So my basic premise here is, let's avoid the reductionistic approach to healthcare. Let's be inclusive. Everything that's out there, there's a benefit, there's a right time. And, sometimes certain things line up for certain people. When we do research, we base research on populations. It's very hard. Sometimes you can have great research that says this treatment intervention is going to be great for this problem, and then you do it to somebody and it doesn't work. That's because the research wasn't done on one person. It was done on a population.
It's maxi, not micro, right?
And so we take the general approach, but this is where healthcare has to be individualized. And when you look at the evidence-based approach, the reason why there's 3 components of it, there's the research component, which we're talking about, there's what the patient wants, but there's also clinician experience, because clinicians have seen in practice the way certain types of people will react to certain types of therapies, or, the extent of the injury, how long it's been going on may change things, other comorbidity. There's so much to consider. Let's not be reductionistic in our approach to healthcare.
Well, like we talked during the break, I know people who run homeopathy clinics. They are dead set. I mean, the big one is vaccinations. They're like, it's a death sentence to them is, don't vaccinate your kids. But then there's others who say homeopathy is complete malarkey.
And again, I think it's a debate, right? That sure can be had, but I think the downfall here is when people just become reductionistic and say that something is absolutely bad or something is absolutely good. We need to understand more about healthcare. We need to keep doing more and more research, and we also, again, have to understand from a general standpoint because the problem with a lot of these things, it starts getting based on individual cases. And you can't not base policies and things like that on individual cases. We have to take into consideration the gross benefit to the gross population.
416-870-6400, star 640 on cell. Would love to hear from you this morning. Marcos, good morning.
Hey, good morning. How are you doing this morning?
Good, pal. What's up?
I got an issue. I don't know if the doctor can guide me through. I'll explain.
I'll try.
I had a problem with the right shoulder. I went to Chinese guy and he fixed that side. Now it's the other side, and now this other side is getting so bad that the movement for it is less than 50%. Either way you want to do it. I did an MRI where it had a little torn, but now the muscle is leaving me and the arm is getting very small. What do I do to fix that?
So let's go back a sec. So the actual muscle bulk is getting smaller?
Yes.
Yeah. So anytime you start to have what's called the medical term for that would be atrophy. So when we look at areas of the body that have started to lose mass, there's usually two causes to that. It's either neurological or vascular. So if there's some type of hindrance in blood flow, that could create that. Or if there's a decrease in nerve conduction and nerve energy, that can create that same type of problem. So likely it's not the tear. The other thing, well, I shouldn't say it's not the tear. The other thing that, again, is hard to assess over the phone is sometimes people have such bad pain and limited range that they stop using that side, and that dismissed use of that limb also may cause a certain small amount of atrophy. But usually in my experience, when I've seen significant atrophy, significant loss of muscle mass, you have to consider the nerve component and the vascular component of that area. And if I had to pick out of one of those two, usually it's the neurological, because there's a lot of other things that would go along with vascular. If you were losing blood supply, you know, your arm would essentially start to die off if you had no blood supply. So that usually becomes very bad very quickly. So if you're calling me about it, I would start to point more to... Yeah, go ahead.
In the mornings when I wake up, I can hardly move the arms. The pain would move from the shoulder to the elbow for a certain time in the day.
Yeah.
Then it moves from the elbow to the wrist another time of the day. And it goes to the palm, and then it keeps repeating itself.
Yeah, and so that type of referral pattern is very, very consistent with neurological types of problems. Could be, and again, when I say neurological, that's broad class. We can start very, very basic with what we would call a peripheral entrapment, so a specific muscle creating pressure on a specific nerve that goes to a specific area. Then we can move towards the axial skeleton, which is the brain and the spinal cord. So maybe something on like a disc herniation, something within the spinal cord, something within the brain, lots of different possibilities. But as a broad class, I would call that, it sounds like a neurological type of problem and neurological in nature, which means you have to do a proper neurological exam, which I always talk about that I do with every single patient. And the things that I pick up are scary to see that things are being missed like this. There's lots of people out there that think they have these very, very small problems and have huge problems. And then I also see people who think they have huge problems and they don't have huge problems. And so get checked. Don't be your own doctor. Don't rely on Dr. Google, that's for sure.
Marcos, how about this? 1-855-55 Dr. Lou, DRLOU. Call that number, and a free consultation, by the way. Get it going with Dr. Lou here. For the rest, give us a call. We got open phone lines, 416-870-6400, star 640 on cell. We'll continue the 2-hour edition of the Dr. Payne Show, Talk Radio, AM 640. The Dr. Payne Show, 416-870-6400, star 640 on cell. And the doctor, before we take a call, is just taking a quick selfie. Isn't that
My
nice?
wife is doing all the social media stuff, keeps bugging me.
Jocelyn working. I can't give her a weekend
she's like,
off,
send me
man.
a picture, and the one that I just sent her, she's like, this is horrible. I can't use these.
Because I'm in it.
Yeah.
Robert, good morning.
Is that me?
Yeah, that is you, Robert. You are the only Robert I have on right now.
Hey, doctor.
How are you?
I had a problem with my arm for about a year. I went through CAT scans, barium tests, x-rays, everything, and they couldn't figure out what it was. And then a buddy of mine who has a massage experts franchise.
Nice little plug there. Yeah.
Come on in for a massage. So he found some muscle knots in between my spine and my shoulder blade. He, kneaded those out like a baker kneads out dough.
Yep.
And pain was gone.
Yep.
So I figure, and nobody can tell me this, but I figure that muscle knot was grabbing those nerves running down my arm and causing the pain. But
potentially, there's something else also called trigger points. And what trigger points are, when you look at the anatomy, there's the nerves come out of the spine at every single level. Now, one corresponding nerve can go to a lot of different areas. And so what ends up happening, and sometimes it may go to a muscle for movement, and another area goes for sensation of a part of the skin, et cetera, et cetera. And so what happens with referral patterns is that muscles can have an area of problem like a knot like you're describing, but can send the pain in other areas. And I see this a lot with, especially in the upper body, like related to desk work, things like that. Even in the legs, there can be areas of problems that are just simply muscular, not necessarily the nerve itself, but the muscle has a problem. The muscle is then sending a message back through the nerve to the spinal cord. The spinal cord is turning the message around because that's what happens. It's a feedback loop and sending it to other areas. And so it's a little bit different than, say, something like a pinched nerve, which is what what we would call radicular, where you can actually trace out the nerve, and referral pain is much more general. So it is possible that if just working on the muscle and there was pain going into the back, that it could have just been a simple referral pattern. And trigger point therapy is very, very effective, which massage therapists tend to be great at that. Acupuncture is also great for that. But yeah, that does sound like what it could have been. Excuse me.
Okay, I just wanted to add that in case we could help somebody.
Yeah, for sure. No, big. A lot of that's the part of when I look at a patient. That's everything you have to consider, right? And you have to consider any potential pain-generating source. That's what I always look for. I hear a problem, and then I think, okay, what are all the potential things that could generate these signs and symptoms that this person is experiencing? And then my physical exam and my other testing is all based on ruling in, ruling out those problems. So after I'm done with the history, after I've finished talking to somebody for about 15, 20 minutes, I'm already 95, 96% certain I know what's going on, just because that's the detective work.
Right.
What someone tells you is the key. There's a saying that listen to what the patient is telling you because they're giving you the diagnosis. And so I listen to that, and my physical exam and my testing is just basically to rule in and rule out the things that I've already considered. And that's the way that, most good therapists go about it, for sure.
416-870-6400, star 640 on cell. Give us a call. We'd love to hear from you. Nick, good morning.
Hi, good morning. How are you?
Good, pal. What's happening with you?
I've got a question about the shoulder as well.
Okay.
You mentioned that it could be a vascular thing or a neurological thing. What if it is in fact a tear, a rotator cuff injury, perhaps?
Mm-hmm.
I think that's. I haven't been to get an MRI done, but I get a feeling that's what it is. What do you think about stem cell injections, shots?
Again, it depends on what the problem is. See, the problem with tears are very similar to saying like degenerative joint disease or degenerative disc disease. You have to understand that a lot of tears are just wear and tear because our bodies get old, and they're not necessarily the pain generating source. So a lot of times what ends up happening is someone has shoulder pain. They go to see somebody, usually their family doctor, because that's the first point of contact. And that family doctor is going to send for an x-ray, and they're going to send for an ultrasound. Mm-hmm. I'm going to tell you that if you're older than, 22, 23 years old.
Which I am.
Yeah, 9 times out of 10, you're going to get an x-ray and an ultrasound back that's going to say, yeah, there's a little bit of mild arthritis there, and there's also some mild tearing in the tendons. Insignificant if it does not correlate with the physical exam. That's where then the next step is getting someone who understands musculoskeletal issues very, very well and makes that the only thing they do to understand, do the symptoms that the person is experiencing correlate with the imaging findings? Because a lot of the times the research on imaging findings for things like tears and degenerative disc disease and degenerative joint disease is about 50-50. And what that means is there's people out there that have really, really bad tears and degenerative disc disease, and they have no pain. And then you have people who have lots of pain and have nothing there. So the correlation needs to be made clinically. It can't just be made on the image. But let me talk about that when we get back.
1-855-55 Dr. Lou, DRLOU is the number to call. Make an appointment, free consultation, and to call on the radio station. We'd love to talk to you. We're here till 1 o'clock today. It's 416-870-6400 star 640 on cell. It's a Dr. Payne Show, Talk Radio, AM 640. Dr. Payne Show, 416-870-6400 star 640 on cell. Anthony, thanks for hanging in, pal. How are you?
Very good. Thank you very much for your time today. And I just wanted to follow up on the discussion, Dr. Payne, on the shoulder and the numbness of that gentleman and the pain in his shoulders. My wife had a severe car accident just days before we were married, and the complications from that were quite grave. Mm-hmm. But over the years, and it's been 30 years that we've been together now, and it's wonderful.
Congratulations.
But she does have this syndrome all the time. Mm-hmm. And what we're doing is we're doing that massage treatment right between the shoulder blades and the spinal cord, and that does relieve a lot of the numbness and the pain in that area. It seems that there's a situation there that does affect that. And my background is kinesiology from Waterloo.
Okay, yeah.
So I have a little bit of an application there.
Yeah.
Of course, you always look for the best solutions.
Yeah.
And I was just wondering on naturopathic medicine, what do you see as solutions on those aspects? Do you see anything else besides, the massage treatments and let's call it the electric?
Well, especially, Anthony, especially when you're dealing with something that's chronic and has been going on for a very, very long period of time. That multifactorial, multimodal approach that I was talking about at the beginning of the show becomes even more important. So throwing everything at it is very, very important. Now, one thing to understand about chronic pain also creates a psychological component. And every time I talk about this, people say, so you're saying I'm crazy. That's not what I'm saying. All I'm saying is that and I'm not saying that you're suggesting that, but I just want to clear it up for everybody listening. Our brain is the processing system for every single thing that happens in our body. Mm-hmm. The same way when you watch a child learn to take their first steps, they are very much focusing on it. And then you see that child at 6, 7 years old and they're running around and they're not thinking about that step. That's the exact same thing that happens with pain. As you start to learn pain becomes something that you start to experience every day because you start to create neural pathways. So, and those neural pathways matter. So there's the psychological component that needs to be dealt with chronic pain. There's the physical component, which are the things like you're suggesting, the massage, the therapy, etc. And then there's also the biochemical perspective of the body and how that interacts, especially with chronic issues. This is where I'm a bit of a believer that, being on hard narcotics and opiates, we see how dangerous it is long term. So in this chronic scenario may not be the best approach. And this is where the naturopathic medicine may play a greater role. Those other things may be much more important in the acute stage and short-lived. You don't want to use those interventions for very, very long. But long-term, having that naturopathic approach. One of the other things about pain is diet, the diet aspect, which I know the naturopaths that I work with focus on that a lot. There are a lot of things in our diet and the things that we consume in the world that are natural, that naturally cause inflammation in our body. And so eliminating those things, and inflammation is pain, right? So eliminating those inflammatory products that we have can help someone's pain levels. But in a case like you're discussing with your wife, chronic, very bad accident, I've seen cases like that a lot, a full multimodal approach of physical, psychosocial, and biochemical is absolutely what you got to throw at it.
Well, thank you very much.
No
I appreciate your time today and God's blessings.
Thank you.
Anthony, I appreciate that. We'll get to Ravi. Hey, Ravi, how are you?
I've seen cases like that a lot.
Ravi. No.
Oh, that's me.
Yeah, that's you talking. You're hearing yourself.
I've never heard that
little
before.
Twilight Zone to show you for it.
Never heard that before.
Turn down your radio.
Ravi, turn down your radio. No, Ravi's not doing it.
No,
all right.
he's not.
We'll get to Ravi later. So a lot said there about all the different components of pain, right? So much goes into it.
100%. And I'm a big believer, and I'm not a believer just because out of nowhere. It's because I've done my homework on all of this. I've studied it for a long time. I've made pain my focus and on how to get people pain-free. And, the other thing is even that term pain-free is Pain Care Canada. I call it Pain Care for a reason because a lot of the times it's hard to eliminate something forever. And that's a big discussion that I have with every single, one of the biggest things that I do is education with patients. People come in and after just talking to me, they tell me, I feel better just from talking to you because they get an understanding. And our healthcare system is so broken in that regard that people have problems and they're not told what's wrong with them. They don't understand it. And education and empowerment is probably the thing that I see most in the research that helps people that live with pain, understanding what's going on, giving them an approach where they can make the difference themselves is absolutely the key to getting better. And we have to understand that all these things, oftentimes you meet people that are just doing the physical approach or just doing the biochemical intervention approach, and they're not getting better, and they're not realizing it's because there's so many components on how you experience pain, from the physical, the biochemical, and the psychosocial, that if you're not intervening in all three ways, how can you potentially make it better? Right? You have to target the problem in order to get better. So it goes case to case. And this is why I encourage people, give me a call, 1-855-55-Dr. Lou. Leave me a message. I will get back to you. We'll discuss what's going on. If I think it's something that I can assess, I'll make that recommendation. If I think you have to go somewhere else, I'll make that recommendation. Simple.
Ravi, we'll try you again. Hey, how are you? Hi.
Yep. Hi,
Hey.
you hearing me now?
Yeah, I am now. What's going on?
So I've had a some mild shoulder pain for about 2 to 3 months, and I thought it was just a mild strain. I went to the doctor.
Mm-hmm.
He put me on naproxen for 2 weeks and rest. it didn't go away. My impression is it wasn't as bad when I was doing light exercise.
Mm-hmm.
I've got a Bowflex, and I just do some general small, routine exercises on it.
Mm-hmm.
So I went back to him, and he said, okay, well, you need to go for an MRI, which is scheduled for August. And he sent me for physiotherapy as well.
Okay.
So I went to the physiotherapist, and he did a bunch of tests, and he says he thinks I've got a frozen shoulder.
Right.
I've started doing some work on it. That's the full session. I'm actually on my way to go and see him now.
Yeah.
I'm just wondering about, should I do an ultrasound? Do I continue doing exercises to help it? What other information? What else?
Yeah, again, and so anytime I deal with pain, again, that's just a symptom. That doesn't tell me exactly what the problem is. And the intervention for, say, a tear versus an adhesive capsulitis, which is frozen shoulder, is very, very different. So the first step in getting better is getting the right diagnosis. Mm-hmm. If you have the wrong diagnosis, we treat based on diagnosis. That's how we work in the medical field. You have a diagnosis, and there's a certain treatment that works for that diagnosis. If your diagnosis is wrong, then clearly the treatment is not going to work. And so that's step one, is how do you make sure that the diagnosis is right? And part of what I also do is second opinions. People come in, they've already been told stuff, they have MRIs, they have things. And we can take a look at it. It's very hard, Ravi, over the phone for me to say, well, yeah, you should be doing exercises or you should be getting an ultrasound, because, again, I have to do a thorough assessment in order to understand exactly what's going on with you. And based on that, then we come to a diagnosis. Based on that diagnosis, that's how I make my treatment recommendations. I give the very best evidence-based approach and answer to the diagnosis for treatment based on the diagnosis. Does that make sense?
Yeah, no, it makes sense. I mean, I'm a pathologist, so I understand.
Oh, then no one's going to understand it more than a pathologist.
So my question is, I mean, obviously my GP is not a specialist, and he refers me to someone else. My question is a diagnosis from a certified physiotherapist enough for diagnosis, or do I need to go to an orthopedic specialist?
I would definitely say that, and it goes case to case, right? I work with some family doctors who are very, very well versed in the musculoskeletal system, and I work with others that know nothing about it. So and the same thing on the physiotherapist stand front. I know some that are absolutely amazing, and I know some that don't know their elbow from their knee.
Yeah.
So that's the bigger thing. It really depends. If the person that you're dealing with, the physiotherapist, you think is knowledgeable and it makes sense what he's saying. The other thing that I encourage is challenge him. Say, okay, why is it this diagnosis that you believe? Show me, because an adhesive capsulitis, a frozen shoulder, has certain characteristics associated with it. The first stage is limitation of range of motion. So that's the first thing I would say. That's why it's called frozen shoulder. So if you're unable to move and there's a tightness versus a weakness that restricts that motion, it already sounds more like a frozen shoulder. So if you think the person that you're seeing is good, then I would definitely probably take someone who understands more about musculoskeletal issues over, a family doctor that maybe isn't as well versed. But again, your family doctor may be well versed in that.
We'll take a short break. Your phone calls, 416-870-6400, star 640 on sale. Lots to go right here till 1 o'clock today. The Dr. Payne Show, Talk Radio, AM 640. We are getting to your calls as we go through here. Caroline, welcome. How are you?
I'm good. How are you?
Good. What's your concern?
So, I have apparently so it's I have a tear in my knee and a sprain in my knee.
Okay.
And it's a I can't even say these words.
Meniscus?
So yes, that's the tear I have. And so they wanted me to see a surgeon, and I have an appointment for next week because the MRI came out like that, the X-ray came out, and I've been seeing an acupuncture.
Yep.
The very first day I did the acupuncture, when I got off the table, I could walk, and it was like I could walk, and that was the first time in months.
Right.
And I've been every week, and for about 3 weeks, I don't feel the same pain.
Mm-hmm.
Is that normal, or am I masking it?
Well, I think what's important is that you're better, and I think that's the important thing to focus on. With tears in the meniscus, the thing here is a lot of knee surgeons, that's like their bread and butter is doing scopes for simple meniscus stuff, and then once it's a little bit more serious is doing the total knee replacement. But again, going back to the way I started, I'm always a believer of try more minimally invasive procedures before you jump to anything like surgery. And in fact, I work actually with a few knee surgeons, and they would say the same thing. We'll try some therapy before you do it, and if it gets better, then great. And if it doesn't, then we'll consider it. But I think if you've done some type of an intervention and you're better from it, placebo is a very, very important thing in healthcare. And it doesn't really matter at the end of the day whether it was the actual acupuncture or the belief that you had the acupuncture that got you better. I think the important thing to focus on is that you're better. And sometimes meniscal tears can kind of get better on their own too. Natural history. Sometimes they're not horrible. It depends where it is, the type of tear. All those things matter towards the prognosis. But I would say, again, the important thing here for you is that you're better. And if you're better, I don't know that jumping to surgery or you could also, the other thing is go do the consultation with the surgeon, right? And get their opinion. They may very well say, well, the same thing that I'm saying, you're better, so you don't need anything besides just getting that opinion.
What I'm worried about is I did this in the end of October, early November. We thought, because I have Crohn's,
right.
So all the symptoms, we thought the Crohn's had gone into the leg, from inflammation. And so I was going through this up until about a month ago. I've just been dealing with this horrible pain. Like I can't get down on the carpet with kids. I can't do anything. And now I've been doing this. And what I'm worried about is that, if I go and do all the things I want to do, am I going to make it worse because I'm masking?
Right. And so,
what I mean?
Yeah, I get what you're saying. And so this is the psychosocial component that I talk about pain. One of the things that I'll often talk about with patients is what's called fear avoidance behavior. So because you have an issue, you're afraid to do things because that fear that you may make it worse. The thing that I could tell you is this. Number one, everything that you're going to do, gradually reintroduce it. And your body is very, very smart. Listen to it. If you start to reintroduce something and your body says, okay, it's starting to hurt, you feel pain in that area, just dismiss what you're doing, right? So you should base your fear of movement on actual fact and not just the perception that it could potentially hurt it. Does that make sense? Do you get kind of what I'm saying?
Perfect.
Yeah. So I would say that, reintroduce those things, see how it's going. If you feel, no, this doesn't feel right, then stop. Base your fears on reality, not just perception, is very, very important in pain management.
Brian, we'll squeeze you in here before the break. What's going on with you? Hey, Brian.
Hey there. I'm interested in knowing, in Canada, with intravenous, can you either get chelation therapy or vitamin C?
Can you get those things from a naturopath, you mean?
Yeah, anywhere in Canada, because I appreciate the study you guys are talking about, the whole vision, but I'm aware of it in the U.S., but I can't seem to locate whether you can get that chelation, the intravenous chelation.
Yeah, our call screener has your number. I'll speak to the naturopaths that I work with. I can't say that I can give you a 100% answer right now, but I can definitely find out for you, and then I can give you a call and let you know.
Brian, we'll follow up with you for sure. Everyone else, so 1-855-55 Dr. Lou is the number to get that free consultation happening. Go see Dr. Lou as soon as you can. We got open phone lines. You want to call through. By the way, we're not done. We're here till 1 o'clock this afternoon. 416-870-6400 star 640 on cell. Dr. Payne Show, Talk Radio, AM 640. Dr. Payne Show, call that number. Free consultations as well. You're on Twitter and Facebook as well, right?
I got my wife. She takes care of all that stuff, and she's bugging me right now to tell everybody to add me. Facebook, Twitter, Instagram. Just type in Dr. Lou. You'll find us, or at Pain Care Canada. A lot of cool stuff that we post all the time. I go through everything. I'm just not the best tech guy, but my wife takes care of all that stuff, and it's all approved by me. But a lot of these things, great articles, great tips on pain management videos. So, add us and follow us, and then that way you can get the help that you need day to day. We'll bug you on social media.
416-870-6400 star 640 on cell. Scott, thanks for hanging in. How are you?
Not bad. Yourself?
Good. What's going on with you?
Well, I have an MRI result in front of me. Just wondering if I could give you a quick breakdown of it.
Give it to me. Go to the. Don't read the findings. Go to the impression. That way, that gives me the diagnosis.
Okay, impression. I don't really know what that is.
It should be the last section. It would say clinical impression or diagnosis. Usually it says impressions.
No, all I got is the findings.
Oh, okay. Well, give me the findings.
Okay, it says there's moderate grade OA end plate changes and severe DDD at L5S1 with moderate DDD at T12 L1 and mildly from L1 to L3.
Bingo.
It goes further into L4, L5, mild to moderate annular disc bulge, severe ligamentum flavum hypertrophy, and mild apophyseal OA causing mild to moderate central spinal canal stenosis, mild bilateral
neuroforaminal impingement, probably,
Goes into L5S1. Moderate annular disc bulge, moderate ligamentum flavum hypertrophy, and moderate apophyseal OA causing moderate.
Okay.
And a
so I already know what the rest is going to say because it's very, very common MRI. How old are you?
I'm 32.
Yeah, 32. So some of that stuff, again, the mild OA is, again, and degenerative disc disease is wear and tear of the spine. It's bound to happen. Small disc bulges, again, as things wear, the space for the disc diminishes, things start to bulge out a little. The canal stenosis, again, as you start to get arthritic changes, wear and tear, every single hole that's in the spine for a nerve for the spinal cord is going to become a little bit more closed. Now, like I always say, the next step is, does what we see on that MRI correlate with what you feel day to day and with your physical exam? So what's going on with you?
Well, I can't even really stand up straight most days. It takes very long to get from point A to point B. My quality of life is severely diminished.
So what originally happened? Like, how long has this been going on?
Originally, I think it's about 6 years ago, I hurt myself twisting at work. A big bulge come out on the side of my spine. Went to a doctor. He said it was RA. Give me some arthritic medication. Sent me back to work.
Right.
A few years. The pain actually kind of went away about 6 months after the initial injury. So I continued to work, and then over time it just started to come back slowly. And now within the last 8 months, it got to the point where it hurts to wipe my own backside some days, right? I don't know how else to word it. It's bad.
Yeah. So what have you done from a treatment standpoint?
Well, just the MRI. They told me a surgeon.
So you've done no therapy whatsoever?
I have no idea what to do.
Right. Okay. So then that's a big problem because it does sound like on the initial impact, usually when people say I was twisting and bending, that usually points me to disc issues because that's usually how problems happen. And then, that leads to a disc problem, again, leads to back pain, which over time leads to the learned component of back pain. And then you get the onset of what we would call chronic mechanical low back pain, which is, it sounds like what you have. But in the absence of any intervention, anytime you have a physical problem, there has to be a level of physical intervention. And so you do need some type of therapy. In terms of exactly which therapy you need, that's, again, a harder question to answer just, over the phone here and on the radio because I need to assess it. I need to see clinically how you're presenting. Where are there limitations in range of motion? Are there any specific orthopedic findings, et cetera, et cetera? So definitely something that we can take a look at. I see you're calling from up north somewhere. We have a provider network all across Ontario, so we can get you somewhere to get this checked out. But I'll definitely give you a call after the show, and we can talk a little more.
Scotty, moving forward, 1-855-55 Dr. Lou, DRLOU. Make that phone call, free consultation. Follow him on Twitter, Facebook as well. And for your phone calls, we'll take a short break over the top of the hour and get right back into our second hour here. 416-870-6400, star 640 on cell. Hour 2, Dr. Payne Show. Coming right up, Talk Radio, AM 640. Make that consultation, make that call. Follow him on Facebook, Twitter as well, and Instagram. 416-870-6400, star 640 on cell. Donna, thank you for hanging in. How are you?
Good. How about you?
Good. What's your concern?
I've been diagnosed with severe psoriatic arthritis. It's very, very painful.
Yeah.
The only thing that the doctor, a specialist, has found is that I have found that works for me is prednisone.
Right.
And the doctor wants to take me off of it all the time. She's always, saying that I shouldn't be on it for a prolonged time.
Yeah,
so I've been on it now 3 years. So how bad is it? Because I've talked to other people that have been on it for years.
Well, okay. So let's start with a couple things. Donna, how old are you?
58.
58. And any history of osteoporosis in the family?
I don't know about. I'm not 100% sure about that, but she did just tell me my last visit that I have osteoarthritis too now, though.
Yeah, not osteoarthritis, osteoporosis, which is when bones actually start to lose their density. So she sent you for DEXA scans to look at your bone mineral density. I mean, the big thing with osteoporosis is it's more common in postmenopausal women. So you're right around where it would be the most common. The issue with prednisone is it's a corticosteroid, and the biggest thing with it is it decreases bone mineral density. Now, prednisone is a very, very strong corticosteroid, and it's great because when people are in very acute scenarios, like you get someone with a severe pneumonia or whatever issue, like really bad, you give a prednisone, it'll clear a lot of things up. The problem is with its prolonged use can lead to a lot of problems. So even in those instances where we have patients that we got to give them prednisone for a short period of time, when you're on prednisone, even for a short period of time, I forget what the exact numbers are, but it's pretty significant. The increased risk of fracture, especially somewhere like in the femur, that can be potentially very, very dangerous. So prolonged use of prednisone, could be very, very dangerous. The next thing I wanted to ask you with the psoriatic arthritis, where exactly do you have pain?
Mostly everywhere.
So it's widespread.
I understood it's in my blood, like it's widespread. So it feels like it's in my flesh. It's not in any one bone or any one area, but it does hurt. Let's say more in my hands and my wrist and my arms. And,
So anytime you start to talk about like a psoriatic arthritis, that's an autoimmune disorder where your immune system, your blood, is attacking your body, and usually it'll attack joints. And, psoriatic arthritis is one of those things on the autoimmune arthritides where, if you can't find something else that has, like a rheumatoid arthritis that actually has specific findings, or like a lupus or an ankylosing spondylitis, and there's a history of psoriatic arthritis, then it's termed psoriatic arthritis. Regardless, it's autoimmune, which is the important component here. I've seen clinically, you're right, it does tend to affect people mostly hands, neck, and knees, and in the sacral area, for sure.
I've had a lot of neck pain lately, so that explains that.
Yeah, so definitely there's an inflammatory component there, right, which is what an autoimmune problem is. What other medications have they tried with you?
Celebrex, and also I'm taking Plaquenil, which I don't think the Celebrex worked for about a year,
right,
and then quit working, and then so I went back on prednisone, and then now she tried to put me on Plaquenil, and with limited prednisone. But now that's not.
Yeah, I mean, either. Again, I would encourage you to go back, speak with that rheumatologist, start getting some plan. The other thing that becomes important with these things is again the way I started the show, that there's the biochemical interventions. You may also want to consider throwing a lot of other things at the problem so that you can minimize the amount of biochemical intervention that you have. And what I mean by that is start doing some therapy with somebody who knows a lot about psoriatic arthritis in terms of a physical perspective. Maybe dealing with a more natural approach as well. Also continuing, the medications that are required. Another big issue with autoimmune disorders is, again, the psychosocial component. So working with a team of healthcare professionals all dedicated to different areas of that spectrum of interventions is going to be very important. And what it could do long term is minimize the amount of biochemical intervention that you have to have. Because again, prednisone over a long period of time can be potentially very dangerous, and should be something that you find a way to try to minimize. And that's exactly why your rheumatologist wants to minimize that.
Yeah. I understand that, but like when you're in much pain, there's nothing else that works. I don't know what else.
Well, but that's what I'm saying. There are other things that work if you take it from a full multimodal approach. So let's have this discussion a little bit more off air, because this is when it starts to border on very, very specific. And I'll give you a call. I believe our call screener has your number, and we could touch base and see if there's anything else we can do.
Donna, there's also 1-855-55 Dr. Lou, DRLOU. We'll take a short break. Get to more of your phone calls. You want to call through? We got open lines. Love to hear from you till 1 o'clock this afternoon. This is a special 2-hour edition of the Dr. Payne Show. 416-870-6400 star 640 on cell. Talk Radio, AM 640. Give us a call. We'd love to hear from you. 416-870-6400 star 640 on cell. Eric, appreciate you hanging in there, fella. How are you?
Oh, I'm good, man. I'm good.
Good. What's your concern?
Oh, no concern. I've actually been waiting for a longer program so I can for sure just keep calling in and actually talk to somebody that's in the healthcare profession.
Cool.
Okay.
Registered doctor. So, hi, Dr. Lou.
How are you?
Good. Yeah, I'm very well. Thank you. So, I did have a specific type of question.
Sure.
In your profession as a medical practitioner, have you ever been introduced to the concept of the photoelectric effect that was what Einstein actually won his Nobel Prize for versus gravity, or M equals mc squared, that we always see on the memes online?
Right.
But the fact that we have two photo concentration devices built into our head called our eyes, and we're told to shield them from the sun, when that's actually providing 2/3 of our cellular energy in ATP, which is the currency that we do everything from thinking to moving with.
Right.
I was wondering if you'd been introduced to that concept, and if you'd ever heard of a doctor named Dr. Jack Kruse with a K.
I have not been introduced to the concept. I have not heard of that doctor.
I'm so glad that you said that, because now I know that I'm the person that told you, and I can have that satisfaction.
All right. However, I do agree with you with another important thing that happens. We often talk about vitamin D and the great exposure that we get to the sun. And actually, the majority of vitamin D is actually absorbed around the eyes. So I agree with you on the point that we're always being told to shield our eyes and not realizing the benefit that comes from some exposure.
Sorry, and I'm a talker. I apologize.
Well, you know what? I'll give you a couple minutes. You go for it.
It's a daily, but I just don't want to appear rude, because I sometimes have a little bit of short-term memory stuff, so I have to kind of plow on. So, if we shield our eyes from the sun at any time, other than if we're in front of, like, say, a large body of water and we're getting complete, like, reflective surfaces bouncing it back to us in further concentration, that's not normal. Or if you were skiing on an alpine mountain,
driving when it's a snowy day,
yeah, you have to wear like polarized sunglasses to totally block that, because it is actually
it's blinding,
cause immediate damage. However, if we do not repeatedly expose ourselves in our own natural environment, we do not develop what's known as a solar callus on our eyes and in our the way our collagen develops in our skin. And that is our body's way of allowing us to go longer and longer in the correct amount of sunlight and generate that pre-vitamin D that begins the process of photosynthesis. And that's the only way that it happens. So if we're putting on sunscreen and we're putting no sun on our eyes, then we're actually decreasing our ATP production at source from 2/3 of what makes our ATP. So Dr. Kruse, who's he's like a Renaissance man. The word doctor means teacher, and he is the epitome of a teacher, because he's actually teaching people, regular people, and he has a spot on his site for doctors, because he teaches people how to talk to, people that are at a very high authority level, to be able to say to them, hey, can you come and start talking to this guy, because he's got all these protocols on his site, and he's giving them out for free, and it's based on the most current in the medical research library that only he has access to, or you as a doctor, Dr. Lou, have access to. The regular citizen, unless they pay a lot of money, can't see those things.
Well, you know what, Eric? I think it's a very interesting thing. I will touch base with you. We could talk more about it. We do have some calls that we have to get to. But again, I'm always a believer that learning new things is very, very important. And I'm never afraid to say when I don't know something, and I don't know very much about the photoelectric effect theory that you're speaking of, but I definitely would love to learn more. So, yeah, we'll touch base on that.
Hey, Scott, how are you?
How you doing?
Good. What's going on with you?
My phone is crapping out. So
no, you sound okay.
If I lose you guys, just carry on without me.
I got you.
All right, we'll definitely do that.
All right, I was watching a lot of Dr. John Bergman from Huntington Beach, California, about his chiropractic adventures. And something came up with what's been bothering me for decades, his hiatus hernia. And I know I can usually control it if I stay away from grains or wheat products, or because I don't have the inflammation in that area. But that's separate to what apparently it can be cured or stopped with thoracic adjustments or something, and physically pushed back down through the diaphragm from externally. Have you heard about that?
I have. I would definitely say that the research supports more your original approach of diminishing the foods that cause inflammation. There's probably no good research that I've ever seen. And again, I'm a chiropractor myself, actually. But there's nothing that I've ever seen. And I am somewhat, sometimes you have to be, what's the right word so that that I'm not offending anybody, but there does need to be research behind things. And I do, when you look at what a hiatal hernia is, it is often more related to diet than it is anything else. And I would say that that's the primary intervention that you should be taking to help it. And that's how you kind of started it, by saying that I can control it by doing those things. And the important thing to remember is that anytime you develop an issue, you very rarely ever get rid of it forever, but you learn how to manage it. And so I don't know that, I can't say that if someone goes to get thoracic adjustments that it will help their issue, because it may just be a placebo. But there's no good research that I know that suggests that that would be the best treatment intervention for it. Having said that, are there clinical cases of people who have done thoracic adjustments and gotten better from it? Probably. But, then the question becomes, is there an actual link or is it placebo? And that's what we have to try to decipher in our practices day to day. So I don't advertise that way in terms of that I could help a hiatal hernia with any type of manipulation to the spine. I would say that the diet approach is better.
Okay. The combination of the adjustment and apparently strengthening the diaphragm itself, but at the same time or before or after, physically actually pushing that part of the stomach that's come up through the diaphragm back down through the diaphragm region. I don't personally like things that are placed in my body literally out of place, where you can see it or my friend who does ultrasounds, he could see that I had a hiatal hernia because it pushed against the aorta, the aorta or something. And I just don't like things being out of place. But if there's no physical manipulation that can be done, then
the thing is, things out of place. There's a lot. We have what would be the ideal body, and very rarely does any individual person have the ideal body, right? So there are always things that could be more optimally set up. Like I meet lots of people that say, "Oh, I have this curve in my spine," and again, it becomes, is it clinically significant? And find me a person with a perfect spine that has perfect curvature. Like it just isn't. It's not realistic to think of that stuff. And, a hiatal hernia, like you're saying, it's something that maybe, I guess, should not be there or would be considered abnormal. But again, the important thing is when you look at something like that is, okay, fine, accept that it is what it is. How do you get it better? And again, from what I've seen, my recommendation would definitely be the dietary modifications that help more so than anything else that I've seen.
416-870-6400, star 640 on cell. The number you want to call. Got open lines. Want to call, want to talk, got some questions, bring them on. Dr. Payne is here till 1 o'clock this afternoon. Free consultations, by the way. You can email info@paincarecanada.com. He's on Twitter, Facebook under Dr. Payne. And the number 1-855-55-Dr. Lou, DRLOU, to book that free consultation. Get it happening. More of the Dr. Payne Show coming right up. Talk Radio, AM 640. You got time to call through 416-870-6400, star 640 on cell. Yeah, you got something on your phone.
I'm getting bombarded again from the wife about social media. So I was wrong about Instagram. It's Dr_Payne_ is where you'll find us on Instagram.
You're taking beats after the show. Get it straight, man.
She keeps messaging me about this stuff. But yeah, anyways, I do think it is a good thing. Add us on social media. So let me get this right. Let me look at my phone to make sure. So on Facebook, Dr. Lou at paincarecanada.com. Instagram, Dr_Payne_ again. And then on Twitter, same thing, Dr. Lou.
You sure about that?
You don't look impressed.
You sure about it this time?
I guess.
Do I have to bring your wife on the show and clear this up? Or
She's always asking. She's like, I want to come down one day. I'm like, well, come.
We got quiet phones.
Yeah, we do have quiet phones.
Okay. Before we took all these phone calls, what were we talking about? I can't remember.
I think healthcare
stuff. Yes, okay. Go figure.
The big thing, again, a lot of what we're hearing is one of the things that we got to do here is people are calling. This is very, very similar to these phone calls to what the consultation is. You're going to give me a call, 1-855-55-DRLOU. Hit option 2. Mm-hmm. That's going to let you leave me a message. I'm going to listen to that message. You can. The important things to leave is a name, phone number to reach you at, and a very, very brief description about what's going on, right? Like if it's back pain, just say back pain. You don't have to go into the extent of it. I'm going to give you a call back. We're going to have a discussion about what the issue is. If I believe it's something that I could potentially help, then I'm going to get you in for an assessment. But again, if I think it's not something that I can help, because sometimes people call me about other things, then I'm going to recommend what you should do from there. And what are people coming in for assessments for? Mainly musculoskeletal type of issues, anything pain related, second opinion stuff. People have MRIs, they've been recommended for surgery, or they have an ultrasound and they just want to know a little bit more. That's another thing that I'm doing. Another big thing that I've started to do and getting a lot of exposure on this front is there's a lot of people that listen to the show that have either worked for big companies, and companies are always looking towards health and wellness. I do free public speaking engagement. So give me a call, get me out to your work. I'll come in, I'll talk to everybody about an issue that's of relevance to that workplace. Sometimes I go talk to construction companies, and obviously they want to learn about how to minimize, musculoskeletal injuries related to the physical labor. But other times I go talk to workplaces that, it's mainly...
Sit in chairs.
Exactly. Yeah. So I'm going to modify it. And again, this is absolutely free. So why not take advantage of it? People always, employers always want to do things for their employees to benefit them. Again, even from the employer perspective, if you're listening, you have a group of people, education and empowerment on these injuries is how you prevent it. People are always like, yeah, but don't you need the expensive chairs and the really good ergonomic stuff? No, it's good education is what prevents injuries, because once people understand what's potentially causing their problem, they become aware. When they become aware, they make modifications to change that. So just the good education. And what's it going to cost you? Absolutely nothing. I will come out personally myself, will come out to your work, wherever it is, within reason. Right? And
Vancouver.
I don't know that I'm going to Vancouver, but across Southern Ontario for sure. And I'll come out and I'll speak to your work about whatever it is you want me to talk about. And I think, and I've been doing a ton of these. People love it, and I love doing it. That's my thing that I enjoy the most is talking, obviously.
I never would have
You never noticed.
No, I didn't figure that out at all. 416-870-6400 *640 on cell. Again, info@paincarecanada.com for email and get that free consultation. Now, we talk, and we like to reflect on it every week because we get so many calls and emails about headaches. This is always a big topic, right?
Headaches.
And seasonal stuff, too. I mean, generally now people are feeling good.
Yeah.
Right?
Well, what were we talking about before the end of the show? One of the things that I notice is in the summer, you start to see less people coming in. And why is that? Psychologically, it's summer. They feel better. They're out. They're doing things. And then as soon as you get to September, boom, it just starts. And as you get closer to December, there's just a spike in the amount that people feel unwell. And, it could be, related to the seasons that we have here in Canada. It could be that people just are back to work, whatever it may be. But headaches is definitely something that we see a ton of headaches. And, again, when we're looking at headaches, we have to, usually when I start looking at a headache patient, what I'm doing is I'm determining, okay, is this something malignant, because very bad things can cause headaches, or is this something on the benign side? And that's where you're dealing with things like cluster headaches, migraines, tension headaches. And then the other thing, a big component that I'm seeing, even when people are diagnosed with migraines, which, tend to be more vascular, I usually find that there's always a musculoskeletal component to headaches because of the postures that we're in day to day. There's always a component that the neck, the upper back play in those headaches. The other thing with headaches is, I always talk about it, the headache diary.
Yeah,
you got to track what's causing, when those headaches are happening, and be very, very specific. Write everything down so that you can start to look for common features. Once you find common features, that's when you can eliminate it, minimize those headaches. We've always heard about people, that'll say, "Oh, if I drink red wine, it causes me a headache." But at least that way you can make an informed decision. Okay, do I want to have red wine tonight? I know I may have a headache, but at least that's potentially coming. And that's very, very, and that becomes important. We often talk about headache diaries, but I have recommended to other people just general pain diaries. Write down everything around your pain. It allows you and your practitioner to look for common features that you can eliminate.
Got open lines. You want to call through till 1 o'clock, 416-870-6400 *640 on cell. Would love to hear from you. Dr. Payne Show, Talk Radio, AM 640. Dr. Payne Show till 1 o'clock, 416-870-6400 *640 on cell. Again, free consultations. Get that initial step going, right? Make that phone call and talk to you. At least get a baseline of what's going on, right?
It's just a conversation at the end of the day. A lot of people, we have a telehealth line in Ontario that's provided through OHIP, and sometimes you have to wait for hours. And obviously, that's more emergency cases. So obviously, if you're having an emergency, don't call me. Call 911. But for a lot of these low-level aches and pains, give me a call. It's a conversation. It costs you nothing, and you may learn a lot, and you may be pointed in the right direction, which may be the first step to being pain-free.
And sometimes just that basic conversation, it's amazing how much better someone can feel just by a conversation.
It's crazy. Sometimes I meet people and all they're telling me is, just talking to me made them feel better. But it's not the talking, it's the education component. Understanding is so important towards empowerment to get better from pain. Like I cannot stress that enough, and it's what's missing in our healthcare system.
How about kids? You deal with kids a lot too?
Yeah, we do actually. We deal with a lot of kids. In fact, when you look, people tend to often worry more about their kids and their pets, right? So definitely for sure, any issues with kids, a lot of people, it was funny, one of my massage therapists was talking to me the other day because he sees a lot of kids. A lot of parents are bringing in their kids for massage therapy just to get them worked on maintenance care. But absolutely. And you know what? That's when you can make the biggest difference towards problems, especially if you as a parent know that you have something. Yeah. The way to prevent your kid from getting it is potentially get it checked out and start doing the right things now. And it may not be necessarily treatment, but just simple modifications, daily modifications that you can make that can make a child better. Like one of the things, I'll often get people that come in, they're 40 years old and they say, I have flat feet. I need orthotics. Okay, fine. You know who orthotics would probably benefit more? The kids who you can have some type of an impact because their bones, their tissues are not fully developed. There's still room for change. Right. Versus at 40 years old, you're stuck with what you got.
Yeah. 416-870-6400 star 640 on cell. Elizabeth, good afternoon.
Oh.
You're not Elizabeth. You're Mr. Elizabeth. Hi, how are you?
Not bad at all.
Perfect. What's your name?
My name is Earl, actually.
Earl, hey, what's going on, Earl?
My girlfriend, that is.
Okay. What's the concern?
She's got a problem with her arms.
Okay.
She was in an accident about a year and a half ago, and she's been going to doctors and all of that, but for some reason she had a problem with both arms. Sometimes she can't even sleep on them.
Okay.
We had to have pillars and all that kind of things to keep her going, and she'll be having this headache like 1, 2, 3 times a week and stuff like that. So I was trying to get her to call directly, but I can't find her. So
you've lost her.
So we don't know what the problem really is.
So has she seen any healthcare professionals for this issue?
Yes, she's been in and out with doctors and all of that. But
any therapy?
Yes.
Okay.
And that still don't work. It's not working, put it that way.
Okay. Yeah. Yeah, I mean, anytime after accidents, especially car accidents, like when you consider especially bad accidents, these are big vehicles being involved, and the effects that go through your body, I think, are often dismissed by the general public about like, oh, well, it was just a little fender bender. Yeah, in a 3,000-pound car or whatever, and that force being transferred into your body, can be very, very significant and can cause a lot of different issues. The problem with car accidents, is oftentimes they're dealt with the wrong way. And so, sometimes people focus more on the legal aspect versus getting better. And that could be a hindrance towards getting better. And I'm not suggesting that the legal aspect is not important. In fact, I think it's very important. We've had Savannah on this show before talking about that. But there does need to also be a focus on just simply getting better and doing the right things. The next part becomes, doing the right things. The problem with a lot of the way the benefits work around car accidents is a lot of clinics are just simply focused on passive therapies and not necessarily active involvement of the patient. So, I mean, Earl, there's a lot of things there that could still be causing her symptoms. It's a very, very complicated thing to go through. I'm happy to see her and see if there's anything we can do to help her and assess her properly. Because again, if she's dealing with this, it is something that she should get taken a look at and see if she can get better. And I always do think there is a way to get better, and by getting better, I mean being able to manage it so that you can live daily and enjoy your life, because quality is very important. And that's, we've talked about that with pain, is that pain often isn't a quantity of life issue like some of the other things that we deal with healthcare, but it is a quality of life issue. And I think quality of life we're going to start seeing people are living longer and longer, and quality of life matters very much, and being in pain affects that. And why should it, especially when there are things that can be done? And it has to be multifactorial. That's the biggest message that I think we have to get across, is that pain management has to be taken a look at from all the aspects that contribute to the pain perception in the individual, which is the physical component, the biochemical component, and the psychosocial component. And therefore, the interventions should be tailored towards the same types of things.
416-870-6400, star 640 on cell. A lot of car accident stuff. Is it usually upper body you see and head, or is it all kinds? In your clinic, anyway.
Yeah, I mean, there's a lot of different scenarios. Definitely the whiplash stuff, the neck and the low back, I would say, is, we actually have also an assessment company where people are assessed for car accidents, either by insurers or lawyers. And yeah, I would say, I don't know the actual majority or the actual percentage, but I would say that, neck and low back stuff is very, very common. And again, it just makes sense because of that, that jarring action that happens. Obviously, depending on the car accident, you can have other things, one of the more serious things we talk about is dashboard injuries, and you can get hip dislocations in that regard. But again, the accidents need to be really bad. The other thing that's a big thing is concussions. Lots of concussion, headache stuff. Again, related oftentimes to the whiplash disorder. It's kind of a syndrome that's all encompassing of neck pain, concussion, and headache versus just being three separate things. It's all kind of related, but it needs to be treated the right way. I can't stress that enough. You need to go about it the right way where, yes, you're working with somebody, you're getting a lot of treatment. You can't minimize the effect of the car accident because, again, of how much force is transferred from these pieces of machinery into a human body. And the effects can be quite detrimental and can go for a long period of time. And then, again, there's a lot of, unfortunately, the reality is that there are a lot of legal personnel out there that don't help the situation. And what I mean by that is they then make their, if you're more hurt, there's more of a settlement, right? And sometimes indirectly they're suggesting that people should be more hurt, or the perception that they're more hurt than they really are. And that can lead to some very dangerous things. That's why also picking the right lawyer is very, very important, and using people with good reputations is really, really important because, again, you're going to become what you believe you are. And if all you're being told is, well, do you have this? Do you have that? And it's like, well, no, but you keep hearing it. It's amazing how people start to develop things that they never heard just because they keep hearing about it. And again, that's the psychological aspect.
416-870-6400, star 640 on cell up till 1 o'clock. Give us a call. Talk. Let's hear your stories. Lots more of the Dr. Payne Show coming up. Talk Radio, AM 640. Yeah, it's the number, 416-870-6400, star 640 on cell. Info at paincarecanada.com. You're all over social as well. I'm going to let you reiterate those particular channels.
I got to
see if you get it right. Hang on, Jocelyn.
Open up the text message. Yeah. She's saying, what her last message was? Just type in Dr. Lou. You'll find me. Yeah. DRLOU. I guess it's that simple.
Just totally give it up on you. She's like, all right, dummy, never mind. Just tell him to do this. Victoria, good afternoon. How are you?
I'm great.
Good.
Thanks for taking my call.
Sure. What's your concern?
Oh, I don't have a concern. I just want to verify that Dr. Lou is absolutely right about these children with the feet. Mm-hmm. They should be taken care of when they're first born, instead of waiting till you're older, right? And then now you have to have orthodontists there, right?
Orthotics, yeah. But, and again, it depends on what the issue is. Usually with stuff like that, with the orthotics, you would want them to be at the very least walking already. And, after a few years, and sometimes I've seen kids, their parents bring them in and they're worried about, they have flat feet. And, again, if it's not broken, don't fix it. Sometimes it all goes based on case by case. But definitely if the parent has a history of something, they have flat feet, but they've also had a lot of pain, that then becomes a little more significant because if the child has flat feet, they may develop some pain. You start watching their gait cycle. The other incredibly important thing in kids, more so than external devices, is you can give them simple things to do that can help change their bodies and the way they develop. Simple exercises that are fun to do for kids, because that's important. You can't give them rehab exercises that they're not going to like, but if you give them the right things and the fun things to do, they can do it with their parents a couple times a day over many, many years, and it does help to make a change in the development of their skeletal system for sure.
Well, I had 2 children in the late 70s, and there was a doctor at Sick Children's Hospital who opened up a shoe store in the south end of Timmins area. And I used to spend $60 on a pair of these ugly-looking army boots called Pussyfoot. And they wore them for the first few years of their life. And because I realized that their feet, the bones are soft, let's get them in the proper footwear as preventive medicine. Like you were just saying about, it's better to be preventive than later on in life having to spend that kind of money.
Yeah, for sure. Yeah, prevention. I mean, we're always waiting for this magical pill that will come across that will cure cancer or this or that. The cure is prevention. Is what we're starting to find out, is that these magic silver bullets are likely not going to exist. And if anything, one of the sayings that I always say, the closest thing to the silver bullet that we have in healthcare is really good education and prevention.
Yeah,
that's the key. Is try to do the right things. It minimizes the risk of anything else happening. It doesn't totally dismiss it, but that's why we also have healthcare. So in the unfortunate event that more serious things do happen, you get the healthcare that you need to try to get you better and get back to your
Those
quality
shoes they sound familiar back in the day.
Yeah, I wasn't around in the 70s, so I'm not sure.
No, you weren't, son.
No. Yeah, I know I wasn't. I was born 85.
It's my stripper name in the 80s. Let me ask you something, since you're a chiropractor there, Captain Crunch. That used to be a pretty fashionable thing years ago, that when kids were first born, like right out of the gate, they'd manipulate their spines. Do you believe in that?
Again, it's, I think if there's something that happens in the labor process that is potentially traumatic, might become more significant. And again, when we talk about manipulation in children, it's not like the manipulation that you would do in someone like you. It's much different. It's more like a mobilization, which is just essentially applying light, gentle pressure to the joints to move them to get. The key with what we're finding with manipulation, all it is introducing movement into really restricted areas. That's really what it is, more than anything. So, do I believe in it? Again, number one, you should see someone who's trained in pediatric stuff for the chiropractic perspective, because dealing with a child or a newborn is very different than dealing with someone who's 30 years old. So there are some people that have more specific training in that. And again, it comes down to an assessment. And was there some type of trauma that happened during the labor process that potentially would have created that?
416-870-6400, star 640 on cell. Last 10 minutes of the show here to go. If you're going to call in, this is the time you want to do it as we take a short break. The Dr. Payne Show, Talk Radio, AM 640. You got a couple minutes still to call through and get a hold of Dr. Payne as we're wrapping the show up at 1 o'clock today, the 2-hour special broadcast. Love it. But in-studio question now coming from a longtime producer, first-time caller.
First-time caller, yeah.
Jody.
I read a report a few weeks ago about how knee surgery, we're spending millions of dollars on knee surgery that people aren't really actually getting any benefit from. Yeah. Do you know anything about this?
Yeah, there's actually been some interesting studies done around that. And one of the most significant ones that I can think of was with arthroscopic knee surgery, usually just to kind of clean up the meniscus and stuff like that. What they did is they had 2 large groups of people. One group of people, they went in and they actually did the scope surgery. And when they do these surgeries on either side of the patella, they do a slit to get into.
That's all it is now.
Yeah. And then they send a scope in there to clean it up. Then the other group of people, all they did was, because they were all put under, they just put cuts in the knee and then stitched them back out.
So they look the same.
So they look the same, so that they think they got surgery. They think. That's the important part here. And then they looked at their outcomes following the surgeries at different times. I believe it was 6 weeks, 3 months, and then a year later. And what was very, very interesting was that the outcomes were identical. And so what it basically showed, what was important, was the belief that they thought they had knee surgery is what actually got them better. And, and again, it highlighted the perspective of the placebo effect. And yeah, is there a lot of wasted money in different interventions in our healthcare system? Absolutely. I think we're moving towards a time that we do need to revamp a lot of things and look at better, answers to certain problems and the way they're being dealt with. Because sometimes this is where it becomes very, very important to determine what the actual pain-generating structure is. And again, moving towards these things once you've exhausted other more low-level things. The other thing, too, is a lot of people, they have extended healthcare benefits for the physio, chiro, massage, all that stuff, and they jump straight into the OHIP system. I also believe that the onus is on us as consumers, right? Because although we think our healthcare is free, we do pay it with tax dollars.
Of course you do.
And so if you have extended health benefits, one of the way that you can remove the burden from OHIP, because what's going to happen is as it becomes more and more labored, our taxes are going to have to increase in order to make up for that. So if you have extended healthcare benefits for other things, utilize those benefits to get your treatment that you need. That way you can remove the burden from OHIP. And I think that's very, very important as a consumer of healthcare to be cognizant of that in one way or another you're paying, whether it's through the OHIP system or your private insurance. But that's why we have both. And some people are like, oh, I never, ever use my benefits. Now, I'm not suggesting that you should just go use your benefits if you don't have a problem. But it's incredible how many people I meet that have issues, have benefits, and never go get these issues checked out or taken care of. It's like, well, why not? You're paying for that somehow through your employer or whatever. Why not use it instead of just solely worrying about, well, I'm just going to go to the walk-in clinic and get a refill on my whatever meds or this or that. So, going back to your point there, Jody, is definitely there are a lot of wasted things happening in our healthcare system, and a lot of knee surgery a lot of knee issues could probably be dealt with without the surgery.
And this is probably obvious, but of course your practice, you have private healthcare, OHIP, blah, blah, blah. You work with both?
Yeah, a bit of both. Again, it depends where we got to send you. Obviously, if I'm going to send you for a surgical consult and potentially surgery, well, OHIP is going to pay for that. If I'm sending you to a family physician or a walk-in doctor, then OHIP. But if you need, physiotherapy, it's going to be extended health, or and there's different types of things. We deal with people who are hurt in workplaces, so WSIB kicks in that point. If you've been hurt in a car accident, then you're extended healthcare insurance, sometimes long disability. So usually with any type of what we would call a third-party payer, right? Someone else who, except yourself, is paying for the healthcare. But it does depend on the service that you're being recommended for, will determine if it's covered by OHIP or through some other type of payer system.
How far along in a problem, say, any specific malady, should I come to see you?
As soon as possible.
As soon as possible, right?
Well,
just get on top of it.
The biggest thing is when you meet people who've been dealing with something for months, years, that's already diminishing their prognosis. Now, do you have to come, 5 minutes after it happened? No. And especially sometimes people will have, another interesting thing is people will have knee pain for a day, then it goes away, but then it'll keep consistently happening. Yeah. And then it's not until it's, lasting for a week that they think, oh, I have knee pain. Well, no, you had knee pain leading up to it. It was just very short lived. I would say that as soon as possible is always the best case, but they don't, John, the beautiful thing is they don't even have to come and see me. They can just call me. They don't even have to, or send me an email at info@PainCare Canada about what's going on. And then again, if I think it's something that you need an assessment and potentially some type of treatment intervention, we're going to get you in, we're going to get you started. And, my corporate office, where my central hub is in Etobicoke, but we've got a provider network all across Ontario. So there's no limitations. We can help. Cool. We can help people wherever they are and point them in the right direction. But as a general rule, I would say the sooner the better. For sure.
We'll take it for another week to get a hold of after the show, which is now till next weekend. 1-855-55 Dr. Lou, DRLOU. Just Google Dr. Lou. You get all the contact there as well, because you are completely incapable of relaying social media. Sorry, Jocelyn, you got to do everything. Till next week, info@paincarecanada.com, 1-855-55 Dr. Lou, DRLOU. We'll catch you next week on the Dr. Payne Show, Talk Radio, AM 640.